Hello everyone, this is Dr. Manodip Ach, consultant diabetologist, Dr. Mohan's Diabetes Specialty Center, the #1 chain in India in the field of diabetes specialty treatment for last 8 consecutive years. Today I will discuss a case study regarding a patient with type 2 diabetes. He is Mr. AB, 58-year-old, with a history of type 2 diabetes since last 4 years. He's obese, hypertensive, dyslipidemic, with obstructive sleep apnea. On physical examination, he is pretty obese because his BMI is 32, with blood pressure is hovering around 130 by 82 millimeter of mercury, and heart rate is at 60 beats per minute. Labs showing glycosylated hemoglobin is pretty high at a value of 8.3%, with estimated GFR is 70. So far as lipid profile is concerned, his LDL is pretty impressive at 69 milligrams per deciliter. HDL is quite low, 35 milligrams per deciliter, which is quite alarming. And triglyceride is alarmingly high with a value of 250 milligrams per deciliter. So far as liver function test is concerned, AST and ALT are hovering around 70 and 100 units per liter respectively. So far as medication history is concerned, he's currently on metformin 1000 milligram twice daily. And so far as hypertension, he's on lisinopril 40 mg once daily and metoprolol 100 mg once daily. For dyslipidemia, he's on statin, atorvastatin 40 mg once daily, and he's putting on aspirin 81 milligram once daily. So he's pretty young, he's having a short duration of type 2 diabetes and has no major comorbidities, with no major complications that would reduce his lifespan as of now. He's at low risk for hyperglycemia, so he would benefit from a more stringent goal. However, he's also obese, hypertensive, hyperlipidemic, with obstructive sleep apnea disorder. Now, so far American Diabetes Association recommendation concerns, he should be having a more stringent or strictest glycemic control, where the glycosylated hemoglobin should be kept below 7%. And it should be a reasonable goal. Following considerations we should keep in mind, and that should be taken into consideration so far as determining an individualized pharmacotherapy for him, such as the risk of hypoglycemia, the cost, which is an important factor, the weight factor like weight gain or weight loss, heart failure, atherosclerotic cardiovascular disease, and chronic kidney disease. Mr. AB is a quite cooperative patient. He is willing to start another medication, but he's concerned because he's a bit forgetful. So sometimes he forgets to take his pills and fears that additional pills will only make this condition worse. But he has categorically told that he doesn't want to have an injectable therapy. So in such a background, fixed dose combinations may improve the patient adherence by once daily dosing, less complex treatment regimens, fewer pills, improve side effects profile with compliance. Now, people with type 2 diabetes mellitus patients commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. Monotherapy cannot address these multiple defects and often leads to failure to maintain a glycemic control over time. So current diabetes guidelines all over the world encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. ADA recommendations in such cases of high-risk individuals with established type 2 diabetes mellitus, the decision to treat with a GLP-1 receptor agonist or SGLT2 inhibitor to reduce the major adverse cardiac events, hypertensive heart failure, cardiovascular death, or chronic kidney disease progression should be considered independently of baseline glycosylated hemoglobin or individualized glycosylated hemoglobin target. Now, EMPA-LINA combination, empagliflozin and linagliptin combination is available as first-in-class treatment in SGLT2 inhibitor and DPP4 inhibitor combination group of drugs. Now, we know that SGLT2 inhibitor is a class of novel oral glucose-lowering agents that mediates glucose-lowering action by increasing the urinary glucose excretion via inhibition of the sodium glucose co-transporter 2 in the proximal convoluted tubule of the kidney. The interesting salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of the disease course. Whereas DPP-4 inhibitor exerts its glucose-lowering effect by the elevation of the incretin hormones and subsequent augmentation of the glucose-dependent insulin secretion and inhibition of the glucagon release. So combination of these two agents has a potential to show the additive glycemic control or the synergistic effect due to their complementary effects or synergistic effects. Now, empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus patients, that is the EMPA-REG outcome, reported that a 3-point MACE outcome occurred in a significantly lower percentage in an empagliflozin compared to placebo on top of standard care. In addition, we know the CV safety of linagliptin, DPP-4 inhibitor, was further elucidated in Carmelina and the Carolina trials. Now, HbA1c decrements by empalina with a fixed dose combination of 25 by 5 milligram has demonstrated at least 1.81% of HbA1c reduction at HbA1c baseline of equal to or more than 8.5% at 24 weeks in metformin treated groups. Now, these benefits on glycemic control were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieving HbA1c of even less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve a target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitor has been reported when a DPP-4 inhibitor is added, which is strikingly impressive, perhaps because of a better glycemic control, although the other possible mechanisms might be involved. So in summary, the empalina combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the target HbA1c compared to the individual agents with low hypoglycemic risk. Thank you very much.